musculoskeletal medicine with a specific focus on dance medicine and like performing arts medicine. So it's good to meet everyone, and thanks for coming out.
Ty, you want to go next? Oh, sorry.
George, I think you're just gonna have to call people out.
Yeah.
Ty,
you want to go next? You're next.
Signed in, so.
Sure, yeah. I guess everyone's order is different, but my name's Hethel. I'm from University of Washington, and I'm a rising PGY3 now. I'm primarily interested in pediatric rehab still, but have had a lot of exposure this year, so I'm still undecided. Let's see, I'll call on Jim next, so we can go in an order.
Okay, so yeah, so Hethel and I went to Brody School of Medicine together, so there's a connection there. And so I'm Jim Eubanks. I'm a rising PGY3 here at the University of Pittsburgh, and I'm interested in spine and pain, and in particular, improving the ways that we deliver care, because we haven't moved the needle very much, so to speak, on outcomes, and it's time that we try to remedy that. So that's what I'm interested in.
I have to pick the next person.
Yeah, okay.
Pass the talking stick.
Wait, who'd you choose?
Yeah, you.
Oh, I didn't hear it. So I am Chelsea Frost. I am currently at University of Virginia. I am an outgoing PGY4 / chief resident. I'm going to be heading down to Emory in Atlanta for an interventional spine fellowship. It's one of those NASS accredited ISMM long name thing. So obviously I'm very interested in like spine sports aspect. I've done a lot of research through that. But originally from Florida, and this one's my dog, Piper. So, Anchor, you're next.
Hey everyone, my name is Ankur Patel. I'm a rising PGY3 at New York Presbyterian, Columbia, and Cornell. My current interests include pain medicine, particularly with neuromodulation and cancer pain. But we'll kind of see what goes on the road.
Awesome. We got a great mix from residents all over the country with a lot of different interests. So this is fantastic. So we'll roll right into it. We have some pre-submitted questions, so we'll run through those first. We'll go for about an hour. If we have time at the end, we can definitely take questions in the chat. So if anything pops up that comes up on your mind with any of these answers, just feel free to use that chat. I'll keep an eye on it, and I'll try and address those at the appropriate time. So first, I guess we can go in reverse order. So we can start with Ankur and work our way back through the panel. Our first question is, what are some of the most important takeaways to gather from PGY2 year?
I mean, transitioning from intern year to PGY2, it's a big change. You're kind of going from like that internist role to like a physiatrist role. And I think the biggest takeaway is to kind of really just find your groove. Like that first couple of months it takes for intern year to kind of feel like a little bit seasoned, to kind of feel comfortable with what you're doing. It's going to be the same transition, probably a little bit quicker, especially because you kind of have a good foundation in medicine before you start. I'll say like my big takeaway is just try to figure out, have some ideas on what you would like to do, like what you would like to pursue in terms of the subspecialty, or if it's general, try to seek out some mentors along the way, and just really have fun. It's a great field. You'll meet a lot of people. PGY2 it's a great time.
So this is I feel like this is gonna be a lot of, I echo that. At UVA, our second year is all inpatient, so I definitely agree with everything that Ankur said, that having that medicine foundation is great. With us being all inpatient, like if you're going to be starting on an inpatient rotation, definitely reach out to everyone who's going to be on the team and be open to whatever they're saying. I know Nick already said this probably in in one of your prior tweets, like earlier this week or last week, that you just need to be open to all of the team members and be willing to listen to what they have to say, what they want to teach you, but also be sure that you don't let them take advantage of you. Like, yes, be open to everything they're saying, but also remember that you are a doctor too. And so don't just be willing to do any tasks that they give you. You're going to be busy as it is. And so you're really going to need this time to learn how to manage your time better. So if you already are having a busy schedule, if someone comes up to you and says, hey, can you do these extra things? Be okay with saying no. Like, you need to focus on your own wellness at the same time. And this is a great time to start learning how to balance things.
All right. Yeah, great. So, my view is that in PGY2, kind of like Chelsea was saying, it's heavily inpatient focused for most people, and that will reflect their experience. It's really the time to learn how to be a rehabilitation physician. So you want to learn the logic of function or the logic of rehab. This is the time to do it and kind of lay the foundation from which you're going to build on moving forward. So even though there I think is going to be a strong drive if you have pre-existing interests to sort of move in that direction rapidly. I had a really good mentor when I was a fourth-year medical student and kind of traveling around looking at programs, who is a specialist in a particular field, which I won't mention, but said, you really want to be thinking about becoming an excellent generalist physiatrist in your early course of rehab residency. So that's something I would sort of emphasize, because that's the foundation which you're going to build on and will differentiate you regardless of how you specialize or if you specialize moving forward. So that's one of the things that I would really emphasize and tell people to be mindful
of. Sort of going off of that and what everyone else has been saying, I think the biggest transition for me was kind of what we've been discussing, moving into a team role. I know being an intern, whether I was on surgery or medicine, it was just me and my senior. And here, at least University of Washington, we don't typically have seniors. We have people available to ask questions for, but you are the person that people are going to, the person from PT, speech, OT, they'll all come to you with the question. And sometimes it's hard to manage all of that. So I think it's finding a good way to communicate with everyone and setting boundaries as well. You can't update everyone throughout the day. So try to update one person and tell them to pass it along to the team. And, it's not just your responsibility to report everything at the team effort. So it's really just finding that balance. I know it's going from being alone to all these people. So finding that fit is a bit hard, but just to be prepared for that is good to think about.
So first off, for those that are transitioning from intern year to PGY2 and those that are going to be interns, congratulations, this is a huge deal. You guys have made it to your rehab part of residency. You are finally into what you match. So first off, congratulations. One of the first pieces of advice that I always give people as they kind of transition into a brand new world, because the rehab world going from intern year to PGY2 year it's very, very different. Yes, you gain a good background, you get that good medicine, surgical knowledge, but don't be scared to feel like an intern. I felt very much like I was kind of repeating at first, but then you learn how to adjust much better because you have that experience. But I always tell people two things, is that you can control with your rotation, you can control your attitude, and you can control your work ethic. You can't control when the patients, if they're going to crash, if they're, going to have to be, this medicine, that medicine, you can't control those. You can control the two things. And so no one is going to expect you to come off of an inpatient internal medicine rotation and you go on to, let's say, the stroke unit and be an amazing stroke physiatrist. No one in the country from an attending perspective is going to expect that. So be open to learning, read, I know we'll probably get into some of the sources, but those are if you have a good attitude and a good work ethic, then that will take you so far in not only your residency, but also in your career. So I second what everyone else said, but those are the two things that I try to really tell people as you transition, because it's an awesome new world that you guys are about to get into, both those going into intern year and PGY2 year.
Awesome. Those are fantastic answers. This next question is kind of similar along that vein. How do you carry over some of the skills that you gained during your intern year to your PGY2 year and throughout your physiatry residency? We'll start with Nick and work our way back.
So that's a tough question, because you have to figure out what separates you from being that internal med doc or whatever service and kind of focus your intern year had into the physiatrist, right? And so you're going to take obviously all that knowledge that you achieved during that year, but you also are going to have to take it a step further. And so in regards to like the specific question is, how do you retain it? Is that kind of what I got from that question, George, is how do you retain that knowledge? Or
yeah, how do you retain it, and what skills are important to carry over as well?
Yeah, so you're gonna lose some of it just because you may not when you don't see it and you don't use it, you lose it. But just as you continue to take care of patients on the rehab unit, you'll learn how to incorporate those intern skills and then take it a step further and say, okay, how is this going to impact the patient's functional status? And then, how do I get them home or to their next destination? So it'll come. You're going to lose stuff. Just, accept that fact. I'm sure I have lost stuff, regained it, and lost stuff again, and probably will regain it. And so that is definitely going to happen. I think some of the biggest things to retain, though, is that basic knowledge, how to manage AKIs, how to manage just all of your electrolyte abnormalities, how to manage your CHF patients. The basic core internal medicine knowledge is going to go very far with you through your career.
So I myself actually did a transitional year before coming here. And so some of the things that I feel like actually helped by doing that were I rotated through surgery and medicine and other electives as well. And so, that didn't make me an expert in any of those fields, but the key takeaways I took from like surgery, what medications they want held if my patient from rehab needs surgery the next day, that was helpful. Obviously things like making them NPO at midnight. And then rethinking about what medications I would restart after they came back from surgery, if they came back onto our unit. And then calling consults from rehab. When I talk to medicine, I hate not having any foundational information. So doing a quick search on UpToDate, and I'm not medicine anymore, but kind of just figuring out, I was on a medicine team, what would help them help me? So you don't have to be an expert anymore on any of those things, but just thinking about when I was an intern, and you were probably the closest to it out of anyone in your team, of course, what would my team have wanted to know if somebody asked us for help? So that really helped me this year. No one had surgical experience as close as I did, and I think it helped me when talking to surgery teams too. So things like that might help next year.
Yeah, great responses so far. And just to build on that, so some of the things that you're going to gain from intern year will be immediately applicable to your inpatient, particularly your inpatient rehab experience. And you want to apply these sort of well-honed skills, particularly in pattern recognition. So there's common conditions that you're going to see on inpatient rehab and need to identify. That's where you're going to translate what you learn as an intern into your PGY2 year. So we're still, inpatient rehab especially is on the spectrum of hospitalists, right? We focus more on function. We're at a little bit of a different level of care, but it's increasingly more and more acute when patients come to inpatient rehab. So we're a continuum, and there's a lot that you're going to learn as an intern on the medical and surgical side that will be pertinent to your daily experience, identifying pathology and circumstances that are going to need, more of that team workup. So that's something I would certainly want to emphasize. Also, that you are now an intense advocate for your patient in a novel way across the health system. So as physiatrists, we're thinking about these patients in the long term. We're not just thinking about discharging them, from their acute episode. We're thinking about the consequences of their care and how to set up the circumstances for them to flourish. And I think that's something you're also going to see build on from your intern experience.
You gotta unmute yourself, Chelsea.
Sorry. So just kind of echoing what everyone is saying, like what I remember taking away from intern year, my intern year was kind of like a transitional year as well. So it was a mix of like medicine, neurology, and then the clinics, the orthopedic clinics. So what I remember taking away was like learning how to manage the basic medical stuff, like hypertension, diabetes, the AKIs, getting good at that. But then from the surgical standpoint, just being comfortable taking out sutures and staples, and like those are basic things, but like at UVA, we have a standalone rehab hospital, so we can't really have surgical consults coming over to take these staples and sutures out. They'd be coming up after hours. And so if you let them know that you can take those out, they are very appreciative. And so when you need to get in contact with them again at a later point, if you have any questions, they do actually remember that. And so sometimes they seem a little bit more willing to help. I mean, everyone knows that like consulting surgery can get a little scary sometimes. So if you already have that built up rapport, it helps you a lot. I think just really like what Jim was saying, that you have to kind of transition your mindset to that team-based approach. And like intern year, you are kind of on a team, you have those uppers, you have the attendings there. You sometimes will see the therapist around, but I mean, when you're in rehab, that's going to be an even more intimate dynamic. We didn't have senior PM&R residents for us, so we were already, one of our respiratory therapists likes to refer to us as both as the intern and the senior, and so he would just call us the PGY 1.5s. So enjoy your PGY 1.5 year where you are still building those relationships, and just don't be afraid to ask for help. Like any of the consult services, they would be happy to help you rather than you having to send them out for like an acute care transfer, then they have to work it up. They would rather help with that preventative step. So just, I think that was probably the only different thing. Just make sure that you're okay with consulting people. Don't be afraid to do it.
So real quick, I want to echo what Chelsea said. I think that is a super important point to take away is, don't be afraid to ask for help. No matter, there are some places that are standalone rehab facilities. We're also the same here at Kentucky. And, you may be able to, from a knowledge perspective, be able to handle the patient that is crashing or a little unstable, but you have to realize what you can do at your facility, because some facilities are restricted, with what they can do. So, the standalone rehab facility is just that. It's a rehab facility that can do a lot, but it's not an acute care hospital. And so, kind of waving the flag and saying, okay, I need to send this patient out for an acute care transfer is not necessarily a failure, but you don't want to hold on to someone too long because you want to be the hero. The hero may be sending them so that they can be in the acute care. So that is I think a super important, if you take anything from this, I think that's one of the things that you should take from this is know when to ask for help.
Oh, sorry, I was muted. Yeah, just kind of echoing what everyone has said. You'll kind of be surprised on like how much you really retain from your intern year, and it kind of comes down to those core principles, kind of knowing how to communicate. It's right from when you start medical school all the way intern attending. The communication skills that you learn are very important. Know when to call your consults. Like our facility is not, some of our facilities are standalone, but some of them are actually in-house. In the beginning, you'll be very tempted to kind of manage all the medical problems on your own, especially like if you're in med complex service. But you have to kind of remember that you're kind of transitioning that role in terms of being a physiatrist. So kind of understanding their functional needs and their goals and what they're doing in therapy is actually going to be more important. And that you can also kind of reach out to your consultants whenever you need. So they'll always be there on standby. And then just kind of really echoing like everyone said, just kind of work more in like a team fashion. Like listen to your patients, examine them really thoroughly. During my intern year, I did do a prelim year, but I had about a couple months of elective, and I got to do like neurology, rheumatology, different subspecialties and services. And if you have that opportunity for any rising interns, I would say try to take advantage of those services, just because you'll see a lot of those patients when you're on the rehab unit.
Awesome. So kind of building off of that, what are some of the most common issues and calls you get as the night rehab resident?
I would say so. I'll say some of the most common ones. I guess in the beginning, your nurses will be they'll kind of call you for a lot of things just because you're just transitioning to the role. And as you kind of become a little bit more seasoned, they'll know like when to page you and when not to page you. But the most common things are probably just like medications. Sometimes like our EMR medications will fall off. So like right when I get into the night shift, I always check all the medications, make sure that if anything needs to be renewed, I double check with the team while they're there. Making sure that sleep aids is kind of a big thing, and it's really important. You don't want to just put like any sleep aid medication on for every patient, but you really want to make sure that the patients are sleeping well. A lot of things that we did in our rehab unit was make sure that we like have a quiet time. So like after like 10 p.m. after medications are set, the lights are dim, TVs are off, just to kind of promote that healthy sleep habit, so that the next day when the patients are awake, they can really fully participate in therapy. So those are probably like some of my main calls. Occasionally I will have emergencies, and you'll always have them. It's just kind of knowing to be on your, like, that's kind of when you're intern is like kind of you put it back on and just try to start managing things. And I would say, especially in the middle of the night, if you do have an emergency, I would start looking to call your consultants early, just because there's less staff available, and you kind of want to make sure if the patient needs to be transferred, that you can get them to the service that they need to be on in a timely fashion.
Let's see. I haven't been on call for a while, so I'm trying to think back of what we had. We had we had a lot of falls. So you'd have like the TBIs or the strokes that are trying to get out of bed, they're getting restless. They would fall, post-op spines would fall. And at that point, you kind of have to figure out which of these patients do I need to come in and see. Like we take home calls. So which of these people do we need to come in and see? Which of these do we not? So like if if they're on anticoagulation, or if they had a spine surgery, if they had a head bleed, obviously you need to kind of come in and assess them. Stroke patients, it's variable whether you need to come in. Some of them, if they're aphasic, it's probably better to just come in and see them, because they can't tell you, hey, I actually am hurting, or hey, something's different. We had a couple of our nurses would call us at like 2 a.m. because a patient supposedly wants a suppository at that time. So you will sometimes get dumb calls because nobody actually wants to poop at 2 a.m. Chest pain were some of the common ones. Or infection. So like they just suddenly started spiking temperatures. They had been having low-grade temperatures maybe all day, but workup had been pretty normal, and then suddenly they're popping up to a 102. So I think those were probably some of the most common ones that we had whenever I was on call. Yeah.
Yeah, so in terms of, night paging and nursing, it can vary whether you're in-house or you're home call. So at UPMC, we are home call because we exist within acute care facilities for our inpatient rehab. And one of the most important things that I've learned this year is, even though we're residents, you can participate in the education of your nursing staff. So you can help them to understand good clinical decision making when it comes to nursing and night calls. And that's crucial because that is going to be a reflection on your relationships with them. And so you want to develop those relationships. And also it's going to help the culture. So one of the things that recently we sort of transitioned more to are text pages. So that way, particularly if it's not an urgent matter, you can have a sense of what's going on. Often we'll get enough information from the text page that we can respond in full to whatever the question is, and that can, really save and improve efficiency with calls. Chelsea did a great job going over the common calls that we get, falls, mental status change, questionable neuro exam changes. Those are the things where, you really have to put your thinking cap on and be very deliberate about your decision making because you don't want to miss certain things. And agitation management for brain injury patients is going to be a big one. Sleep questions, of course. And, so you're going to develop a gestalt for how to manage those kinds of common questions that you get, which will stem from your training as an intern. So this is just another great example of where you're going to take your training as an intern and translate it in a positive way into your life as a PGY2. So one last thing about this is, if you get that call in the middle of the night, if it wakes you out of your sleep at 3 a.m., which I had a pretty rough call weekend a few weekends ago with a few of those calls, you want to muster the energy and strength to answer and be polite, right? Because you never know what's happening on the other end. And that's crucial because you're always reinforcing the relationships you have with the full team. And that includes even when you're getting calls at night. So just another tip there.
Similar to forming those relationships with nursing, one thing to keep in mind that I always hope people keep in mind when I'm calling for consults is that someone is just looking for help. And oftentimes in the middle of the night when you get a phone call, I remember I recently got a phone call around 2:30 a.m. for cough drops, and it seemed so silly. They're over the counter, and I just wanted to put the order in and go back to sleep. And I opened up the patient's chart, and their NPO, aspiration precautions, cannot have anything in their mouth. Recently aspirated, had a pneumonia, so this patient could not have cough drops. And so things that do seem silly sometimes just are silly, but other times you don't want to miss something like that. So taking it a bit more seriously, even if it seems silly, is worthwhile sometimes, while also providing that education is important. And then depending on where you are, I'm home call too at UW. I would say when you start with orientation, it's great to just ask your co-residents, what would you do if this happened or that happened? Because every institution is different. How people handle falls, how people handle change of mental status, or really anything. Fever, for all fevers, we pretty much go in, and that might not be the same at every institution. So asking that early on can be pretty beneficial. And then also maybe finding someone who could be your call buddy from home. I have a co-resident who I often text if there's something I'm not sure how to handle, or I want to make sure I'm doing the right thing. I just run it by them, not in the middle of the night, but maybe in the evening. So having someone that you can go to, it just makes you feel maybe less alone, and your clinical judgment isn't all on you sometimes. So finding a call buddy, if somebody wants to be your call buddy, can be helpful as well.
So yeah, I'll just kind of recap, I guess, because everyone really hit the nail on the head. You're gonna get really bad and not bad calls. I shouldn't use the word bad. You're gonna get calls at 2:30 in the morning that are the suppository, which sometimes can be frustrating. But again, just like Jim said, is use that opportunity. Do not be rude, because not only will that make your life that much worse, but also you've lost that rapport with that person, and you've lost that opportunity that could be there, just like was mentioned with the cough drops and aspiration. With night call, I kind of separated into two different types of calls. You have your common calls, and then you have your kind of rehab emergencies. The four ones are exactly what everyone talks about: falls, pain. We get a lot vital sign changes. And those are kind of and sleeping aids. Those are kind of the biggest ones we get. And then, with emergencies, it really depends on if you take a home call or in-house call. I think some of the biggest things, if you were to kind of read up on stuff, I know when I was kind of in your shoes, I thought, okay, well, if I'm in the middle of the night, what do I need to read up on? Because my rehab knowledge won't be where it's at as a fresh two. I think autonomic dysreflexia is one. I was scared to death about having to manage that as a fresh two. And so I think that's a good one to read up on. And then kind of the other emergencies are those neuro changes. Sometimes it can be someone is really sleepy, or it could be the subdural that is continuing to bleed for some reason. And so those are, I think, in my opinion, some of the biggest emergencies. And then, a fall can turn into an emergency if they're on anticoagulation. And so sometimes the ones that are common can really turn into emergencies. So, I kind of live by the mantra, treat others as you want to be treated. And, people are just paging you for help. I've never met someone that has paged me just to be mean. There's a reason why they're paging you. So, be considerate, and go from there, and it'll make your life much, much easier.
Just to add in, like our call is actually in-house. So every program will have a different call structure. So I would always say, like, when you start out, definitely ask your upper levels just to see kind of what is appropriate, just so you can have an idea. And like our system was that we had a call buddy the first couple of calls, so that someone was there for most of the night if something were to happen. And just remember that everyone, all your co-residents, you guys are all on the same team. So you should be more than comfortable to kind of reach out to anyone. Like Halo said, I think having a call buddy is definitely really important in the first couple of calls, until you feel very comfortable with your nursing staff, as well as just kind of getting used to the new institution that you're at.
One last thing is, don't forget to get a good sign out from your co-residents. You don't want to be that person that forgets to get call or forgets to get sign out, and all of a sudden you're scrambling at midnight, and come to find out, the person was already kind of on the fence, from a vital sign standpoint during the day. So I would always make sure that I reached out early when I was on call. Our call starts at 5 p.m. here. And so I would reach out at about 3 o'clock. Hey, any issues? Now, they were going to text me anyways, but, be proactive, make sure like you're staying on top of things so that what happened during the day or kind of during the week going into a weekend.
Awesome. The next question we got was, what are the best resources to help review what we need to know on the wards? Send that in the chat.
So is that me to start off, I guess? So I think starting out as a 2, I kind of used Cucurullo just to build that foundation. But Cucurullo should not be your main source for managing, right? It is a board review text, and that's what it is intended to do. But what I did was while I was on the unit, no matter what it was, stroke, brain injury, whatever I was on, is I would have Cucurullo with me, and I would read up on what it was. So in the very beginning, and still is to this day, all the different stroke syndromes, I'm like, okay, well, let me see what Cucurullo says about stroke syndromes. And then I would actually go into Bradham, because I think Bradham is a very good text. And then those would be the kind of 2 things I would rely on. And then also, don't be afraid to go ask your attending. Your attendings are at an academic institution for a reason. They, for the most part, like to teach. And so you could say, hey, I didn't, I'd like to learn more about, pick whatever stroke syndrome you want. And, maybe your stroke attending is like, hey, let's read the rule of fours paper. And, that's how you facilitate learning. So for me, it was Cucurullo and Bradham, as well as searches on UpToDate and Medscape, and then talking to my attending. And that's kind of how I formulated kind of my educational part of my rotation, as well as what the attending had me read, etc.
So I would say in terms of the more medicine-y questions, if you needed a resource for that, I would stick to what you used intern year in hopes of it being the fastest and most efficient way to find an answer that you're looking for, a medication that you're familiar with, and not get bogged down in more detailed articles or resources. So something quick like UpToDate could be helpful for that. In terms of rehab, for myself personally, I have struggled with reading textbooks this year, just trying to manage everything. So I think, at least where I am at UW, we have a really strong lecture series. And what I've been doing is saving the lectures now every time we go through them, because that's where I learn things from, and that's what I want to refer to, because that's where I, build my foundation. And so oftentimes having that lecture to go back and check in on, and the attendings appreciate that too, if it's their lecture and you've actually referenced it. That can be the most efficient way. And then, I'm just bringing this up. I can't really speak to it because I haven't really delved into it, but PM&R Recap is something that it's a board review course that I know that my residency together, we got a discount code for, so I went ahead and purchased it. And I haven't used it myself. Maybe some of us have, but it's sort of like Pathoma in that it offers a lot of videos and something that might be beneficial to you if you liked Pathoma and learning that way.
Yeah, so I would echo the PM&R recap. I think it's outstanding. Alex D'Angelo is the mastermind behind that, and it is modeled off of sort of a hybrid between online med-ed and Pathoma in particular. I used it almost exclusively for SAE this year, and am very happy with the results. So I would recommend it as a resource. It hits the high yield points. From a practical standpoint, on daily inpatient rehab, I did use UpToDate for medications. I liked Hippocrates. It's free to use for medication references. And then for conditions, actually a pretty good resource is either Medscape has a professional app that you can download on your smartphone, as well as Merck Pro. And both of those are free resources. They're leaner than UpToDate, which can kind of get bogged down in a lot of different subtopics. So I liked it for those reasons. And it will contain most of the information that we need for what we manage. And I agree very much about didactics. If you have a strong didactic series or lecture series at your institution, definitely rely on that and use that resource.
I used Cucurullo. I had that with me every day, and so I would just kind of reference it with things that I wasn't sure about. And then I also use the didactic sessions that we have, and our attendings. Some of our attendings were a little bit more, I guess, enthusiastic about teaching. And so, even if I wasn't on his rotation, I would go and ask him questions. He's super smart, and he was always willing to talk to you about topics that weren't even what he's normally practicing in. And so I actually learned a lot from him. And I used UpToDate whenever I needed to look up something medicine-y, honestly. I had a bunch of resources that I had from intern year and being a med student, but I didn't want to bring them with me. So I just used UpToDate, and I found it to be very helpful and useful that year.
Yeah, I think everyone really touched up on some of the great resources that are available. I actually have not heard of a Rehab Recap, so I'll have to definitely take a look at that. But I would say Cucurullo is kind of one of the texts I use pretty much for all my rotations and just for my independent studying. Like everyone said, that it's really like an outline form, so you don't really get like the meat of it. I kind of usually refer to Bradham or Delisa just to kind of dig a little bit deeper and to kind of read a little bit more. On general floors, just like every day, I usually carry around like the PM&R Pocketpedia. This is one of the older editions, but I really like this. I used this when I was a med student. It kind of goes over like all the different areas of rehab in like quick pages, and you can kind of quickly refer to it. And then I would say like your didactic series, your institution, they put a lot of effort into your didactics. Ours are usually a 12-month series, and they kind of really hit all the topics in detail. And throughout our residency, we get about 3 times. So you feel pretty prepared towards the end. So I would say really kind of stick to first, like what really makes you feel comfortable, like what kind of learner you are. You've gone through medical school, intern year. So kind of really stick to the same process that you're comfortable with. And then find some resources. Don't get bogged down with so many. There's a lot of resources. Just pick some that you really enjoy and you really like, and then just go from there. You'll learn. Your most of your learning will be during rounds.
Awesome. Yeah, I'll plug PM&R Recap too for medical students. It is a pretty good purchase for me. I used it over the past 12 weeks while I was stuck home, and I felt like I learned a lot and retained a lot the way that he presents the information. So moving away a little bit from the floors, the next question was, how do you balance your work-life balance along with other scholarly activities such as research, maybe leadership positions in the PM&R and AAP as a PGY2? Like, how do you strike a balance during this time?
So transitioning into PGY2 is definitely, it's a challenge in the beginning, just because it's a whole different environment. So I would say very early on, you'll be presented with probably numerous different opportunities to kind of get involved in different things, research projects, like scholar activities, leadership positions. I would say to kind of really focus on like your work and your life balance initially, kind of really making sure that you are able to kind of balance your day to day. The first couple of weeks of inpatient will be tough. You may have some long hours, and you don't want to kind of take on too many responsibilities early on. But once you kind of feel comfortable and you start gaining interest in different areas of rehab, definitely explore areas. If it's something leadership wise, this is kind of when you can reach out to some of your mentors to ask them if they have any projects. But don't feel like you have to get involved in something from day one. It's absolutely not necessary. Take your time, kind of get a feel for what's going on the rehab unit, and then try to take up responsibility as you feel comfortable.
So I would say like when you're first starting out with PGY2, I wouldn't take on anything else quite yet, at least like the first month. Let yourself get your legs straight, figure out what you need to do, and just kind of figure out like once you've settled into your daily life in PM&R, and that allows you to kind of figure out how much time you're going to have. Are you going to have a lot of free time? Are you already feeling overwhelmed just by doing work, and then you're coming home, and then you have to kind of look at who you are as a person. Do you enjoy being busy, having like your schedule built out hour by hour, or do you want to just kind of enjoy like come home after work, just kind of sit down, enjoy Netflix or whatever, and just kind of figure out what you enjoy. So like PGY2 year, the first couple months, I just kind of did work, came home, that was it. But I mean, I got a dog that year, so I was still able to manage that. I ended up doing a leadership position with a PM&R, I believe. And then I also jumped into research. But I'm also someone who enjoys being busy, like having my day completely blocked, and it makes me feel fulfilled that way. So it's just kind of looking at making sure that you know what your schedule is going to be like and figure out what kind of person you are. Are you someone who wants to be busy or not?
Yeah, so I completely agree with what we've been saying here. You know, it helps to have friend and family support. So if you've got people around you that are going to be supportive of your time as a resident, that's crucial. Also, you have a responsibility to try to maintain those contacts with them and spend time when you can. Some institutions as a PGY2 are more willing to promote you going to conferences, and in those cases, it's fine to do so if it works out. It's not crucial for sure as a PGY2, and some programs, just the way that they're designed, it's going to be really hard to do that. So I would tell everyone not to have any pressure or sense of pressure that as a PGY2 especially, you need to be going to conferences because that's certainly not the expectation among the overwhelming majority of people within PM&R. So you can still be actively involved in thinking about your various interests. You can look for mentors. So, I'm kind of involved in a research training program, RMSDP, which is through AAP. And that's all about connecting with people that can sort of support you and nurture your development. And the crucial thing is that you find people who are able to give you the time that you need to develop the skills that are essential to what you want to do. And by and large, that's the most important thing, is get yourself in touch with folks like that. That will include your seniors as well as attendings or even researchers outside of your immediate department in some cases. But I think that it's appropriate as a PGY2 to start going there and thinking about it a little bit. You're again laying the foundation for your future still as a PGY2. So I think that's the thing that you want to stay most focused on.
I would say, at least for myself, we talk about wellness so much in rehab, and I think it's easier to talk about that for other people than ourselves. But coming into residency, I moved all the way to Seattle from the East Coast. And so I was just trying to adjust into what felt like, kind of what Nick said, a new intern year, and adjust to life as a PGY2. So I did not do too much research or hold too many positions early on. I feel like now, though, past few months, I've had many opportunities, and not being in the place where I feel like I need to say yes to everything and say yes to what matters to me, what I'm interested in, what might help me in the future, whether it be for fellowship or jobs or whatever it might be. It's nice to just get to a place and manage your workflow and then decide what is important to you. And it might be going to conferences, it might be holding positions or doing more research, whatever it is. I would just say, there's so much change involved with starting PGY2, at least if you're not in the same institution. I mean, and then even if you are, there is. So just trying to facilitate and make it easier for yourself to adjust to the workflow, adjust to just learning what's important in rehab, and then building other skill sets and holding other positions after you've kind of mellowed out and adjusted.
Yeah, so I mean, as you can see, there's kind of two different types, and the kind of those in between, those that want to have every minute of every hour planned, and then those that don't. I think what it really boils down to is to be well. I think it really relies on organization. No matter what type of person you are, if you don't want things necessarily planned, or if you want every hour planned, you still have to be organized, right? And so find what works for you, what has ever worked for you in intern year. I would try to adapt that to the rehab realm. I'm a list guy. I'm a list and checkbox. So like everything on my to-do list from the inpatient side, I would have the list. And then, different leadership roles, research projects, etc. I kind of have a list at home that it's like, okay, well, these are the things I need to check off. And so for me, that is what kind of keeps me at least sane. If I don't do that, then I kind of get lost, and it can get, if I'm not organized, then I get stressed, right? And so, I mean, what everyone has said is great advice. I just have to try to be organized, because that in and of itself will help your wellness.
Awesome. our last question, kind of, we're getting close to the end here, but one of the questions that came in through the chat, it's going to be relevant for these PGY1s transitioning into PGY2 during this kind of unique time. Regarding team dynamics, has COVID impact running a rehab team and communication between team members and also family members, just because of the impacts on family meetings and other instances that might not have existed before this situation?
Yeah, so that's a loaded question because I think every kind of facility did it a little differently. We could probably talk an hour about that topic particularly. I'll be short though with that. So at UK, we kind of pared down our teams. So we normally have 7 inpatient teams. We pared it down to 4 and had so that we could have people have vacations and just time off so that they could limit their exposure and not only limit their exposure, but to kind of relieve stress and be well. And so we did that. Now, I will say with the restrictions becoming a little less stringent in regards to visitors, it's getting much easier to do family teaching. So one of the big things you guys will realize is family teaching is a big component about kind of, the patient's next course, right? So getting home, getting to their next destination and following up with them and making sure they succeed. At UK, we kind of had to do some of that over the phone because we didn't allow, there was for a couple of days where we couldn't do family teaching. And then interaction between the staff, you could almost argue that it might have been, I won't say better, but there was maybe a little bit more continuity of care because everyone kind of did a limited schedule with, and so, you were talking to the same person all the time. And so, that I think added a component to it, but it was very tough and, we're still going through it. We're still running at least through the end of June on a reduced kind of team, but as things start opening up, things are getting a little bit back to normal. But I think what you'll find is every facility did it a little differently.
And just piggybacking off of that, I would definitely reach out to any of your residents right now if you have any questions about that, because that is so up in the air and important for you to know. I ask questions about it still all the time. But for my facility specifically, we have 4 different hospitals. They all handled it different, as you can imagine. And we do now just do Zoom or phone call meetings with the therapist as well to communicate that way. Sometimes we have family members join those meetings. Other times it's actually the responsibility of the resident to call the family member and update them, answer questions. So it does at times end up being a heavier workload, non-clinical workload for us. I will say I don't feel like there have been too many things miscommunicated or slipped up by meeting not in person. It's not as fun, but I think we've found ways to work around it. But other policies like wearing masks, how many visitors can come in, that's important for you to know, for you to convey to your patients, but that will change probably between now and when you get there anyways. So definitely keep asking those questions. They're relevant and probably different for all of us.
Yeah, excellent answers. And I know that, we learned a lot from UW in terms of you guys sort of getting this earlier than many of us here in the States. So that information sharing was crucial. That's one of the things that we did as an institution is very early on started inquiring about the changes being made sort of in real time at other institutions who were seeing cases and higher volumes sooner than we were. Being in Western Pennsylvania, we were a little more late to receive the increase in patients, but having those relationships again, whether it's with colleagues or with patients and their families, is crucial in this field. So one of the things that was interesting is we did move to a remote system. So we had about half of our residents inside the hospitals and then half of them in a remote sort of service capacity where we were supporting the inpatient teams. And that kind of doubled for the events of exposures and if we needed to swap out people just to reduce the amount of time in the hospital. It worked out really well. I think, we've all learned a whole lot from this whole experience. And some of the things that we've learned, I think, will stay. For example, we'll probably see a lot more telemedicine, telerehab. We're going to see a lot more virtual didactics, and we'll see experimentation continue throughout the summer and into next year, which is really exciting, actually. And then, the last thing is, from a practical standpoint, as a PGY2, we had to make a lot more contact with families to try to hold things together in ways that are much easier when people can freely come in and out of the hospital, right? Because we, of all the medical specialties, are really dependent on caregivers and family members who are going to support patients for the long term. So that's one thing that was a little different and important about the experience we had.
So this is actually going to be hard for me to answer just because I haven't been on the inpatient side for a while. We did, with the start of COVID and clinics, our outpatient clinics closing, we did end up going to like a rotation schedule to give some time for our inpatient residents to just have a little reprieve from all of the stress from the COVID. So we actually went through a rotation schedule, and each of them got 2 weeks off a month, I believe. So once the clinic started reopening, it was a very gradual reopening. It affects our upper level rotations, like our EMGs. You're not getting as much EMG time. And so that allowed for additional lectures time, kind of like almost like a one-on-one with whoever's doing EMG and the resident. We had some of our clinics went to telemedicine, not a lot, just because like in our spine clinic, it's a little bit harder for our attendings to do a telemedicine if you're having back pain and to really assess you to the level that they would like to assess you. And so most of them opted not to do any telemedicine, but like our musculoskeletal, so like our sports injuries and our running injuries, they did a telemedicine and it worked out great. That was a lot of attending with resident, doing some video calls. Some of the patients preferred just telephone calls, so that kind of made it even more difficult to actually assess a patient. But yeah, it's like everyone said, it's going to be very different how every program is doing it. And then come next year, we really can't say, is everything going to be back to the old normal or things going to be completely changed? So that is a very hard question to answer right now.
So for our institution, for New York Presbyterian being in New York City, we were hit really hard. So our numbers were quite high for many weeks during the COVID pandemic, and still frankly are, but they're improving. So we have about 7 clinical sites that we cover, and our 2 major ones are Columbia and Cornell. So within those institutions, we actually expanded the number of beds that rehab beds. Some of them were converted from medicine to rehab beds temporarily, since we saw that there was a lot of rehab needs for these patients, especially the patients who came off the vent. So we had in our program, we had about 24 residents. About a third of them were redeployed to either to the ICU, medicine teams, or the ED. The other third were pretty much on a night float. And then the rest of them were split between a remote, where they would be helping out the inpatient team from their home, and during the free time, they would actually work with the chiefs, and we would have about academic didactic sessions daily, so about 3-4 hours daily about educational learning, which was really helpful. Now we're actually all back to a semi-normal schedule. Most of our outpatient clinical sites are still opening, but as you can see, like all the institutions had different ways of structuring and going through this pandemic. And I think as we kind of go into the fall and later into the year, I think we'll continue to see changing. So that will be constantly evolving. So I would definitely reach out to your particular institution and your residents to see what's going on there. In terms of the rehab teams, so a lot of it was done virtually for us in terms of our team meetings. Daily and weekly team meetings, we would do them virtually, either on the phone or through Zoom. A lot of the family training was going virtual as well, so through iPads or phone calls, which was actually kind of brought up a different reason we can actually start implementing this into a normal protocol, which is actually really interesting. And then, like Jim said, I think you kind of really have to focus on calling the patient's family daily or multiple times a day. I think that constant communication is really key. For our program, we had a no visitor policy, which was actually taking effect really early on. So the moment they came into the hospital, so some of our rehab patients were probably in the hospital for about 3 or 4 weeks at a time. So they were away from their family for a long period of time. So kind of you're really that bridge to kind of making sure that the family understand what's going on. And then we would try to get them maybe touched in with their own cell phone or iPad, just so they can see their family. I think that was a really important part of their wellness as well as their rehab program. So kind of like everyone touched on, I think this is a really unique time to be in medicine and particularly rehab. And I think we're going to see a lot of changes going forward. Even though we were maxed out in terms of how many patients we can take in terms of acute rehab, we realized that a lot of patients who were being discharged home still needed rehab needs in the outpatient setting. So that was something that we were implementing with their outpatient attendings to making sure that people actually had proper follow-up going forward. And I think we're going to see a lot of that in the future.
Awesome. That was extremely informative. Thank you to all of you for joining us tonight. I really appreciate you guys giving your time. I know everybody's really busy, especially with coming off of home rotations, getting back into kind of the normal swing of things. So we really appreciate your time and you guys doing this for us. If you guys had any more questions that didn't get answered, definitely reach out to us by email or on Twitter, Instagram. We can get you in touch with any of the speakers. They're also all on Twitter. As if you aren't on the physiatry Twitter yet, I definitely recommend that you get on there. We'll have, like I said, we'll have events. We're going to try and shoot for every Thursday around 8:30, depending if it's a East or West Coast speaker. We'll try and keep around this time, so it's kind of a consistent thing. And if you have any questions, if you want to be a speaker for us, if you have any requests for speakers or ideas, we're all ears. We're just a group of students and residents trying to keep this thing going. So we definitely appreciate all the help that we could get. So thank you all again. Appreciate your time and have a great night and stay healthy and safe with everything that's going on.